Thank you for coming for this meeting. I think it's very important that we meet here and we discuss the new therapies. Why is it so important? Because osteoarthritis, which is incurable disease that we don't know how to treat the patients. We can only improve the symptoms, or we can cut off the joint. That's the only treatment we know. And the problem is that it's not only incurable, but also we see there are younger and younger patients coming to our offices, and they seek for the treatment. And those young patients, it's not anymore the disease of 65 or 70-year-old people. Those people who are 40 years old are going to come to your office, and they're going to ask you not for pain improvement. They want to remain active, and they want to do sports. They want to do a normal life. And for many of those patients, I think that the surgery, I believe, is not only option, and we should look for the new potential strategies that can improve the symptoms of the knee osteoarthritis, not only by means of the surgery. And especially that we know that the current standard treatment, which is total knee arthroplasty, is not successful for everyone. And I think that's why it's at least worth to try before we move to surgery, to consider alternative options for those patients, especially because there is an evidence in the literature, and it's very strong evidence that those therapies, the biological therapies that use either a PRP or cells, that they are effective in treatment of osteoarthritis, and especially that we know with the current evidence that hyaluronic acid injections do not work, steroid injections do not work. We have to find something else that can be used for a conservative treatment, or I would say interventional treatment, because this is not really conservative treatment. This is treatment that offers a biological stimulation for osteoarthritis. And there is a very long history of this evidence that those cells, the MSCs, that they can synthesize the broad spectrum of growth factors, and those factors can be used in a variety of situations. They can improve the healing. They can stimulate the cells to produce the tissues in a defect zone. And when about 4 years ago, when I met Carlo Tremolada, and I was introduced by Professor Kaplan to him and Arnold, which he's my guru in terms of biology and cell therapies. When he told me that, Konrad, I want your critical opinion. I want you to try this, and I started very, very soon after I was introduced to Carlo. And when I mentioned Arnold, I think I would like to tell you something about the research that I did with Arnold that is relevant to this topic. Is when I was 15 years younger than I am now, I traveled to Cleveland. I quit my residence in orthopedics for 1 year, and believe me, this was the best year of my life in terms of my education, of course, because I don't know if you've ever been to Cleveland. It's not a very interesting city. But my education was going very well. The social life not. So my goal was to optimize the way that was the Skeletal Research Center, the place where Arnold was invited me. Is they were loading hyaluronic acid scaffolds with MSCs. At that time, we called them mesenchymal stem cells, and my goal was to find the optimal number of cells that should be loaded onto those scaffolds that would make a perfect cartilage. So I was taking a bone marrow from rabbits. I would load it into scaffolds, and I would implant them into a nude mouse subcutaneously. So I was really frustrated after 1 year, because this is my results. it's not really impressive. You could see that in some rabbits like this lower panel, it seems this is the standard procedure that they were using in the lab. So this is 500,000 cell. This is 1 million and 2 million. So okay, this rabbit is more cells, better cartilage, but this one and this one, no. So at that time, I had a little bit more hair, so I could take it off from my from my head, and I was really feeling bad. So at that time, our hypothesis was that there is a strong variability in terms of bone marrow preparations in rabbits. But when I look at it now, after 15 years, okay, I'm orthopedic surgeon, so it took me 15 years to figure it out, that it doesn't really matter how many cells you put on the scaffold. So this kind of supports the theory that there is no the direct relationship between the number of cells and the effect that we're gonna have in the joint. So I would strongly, looking back by this research, I would say that if you put the cells, it probably doesn't matter how much you put them, because the cells are working in a different way. It's not a direct relationship. So until now, since 2014, since April, I did over 300 procedures, which means I used 300 Lipogems kits, which makes Giorgio happy. Not so happy. Okay, sorry. But this represents much higher number of injections, because there was a very small number of patients that had only one injection. So my record was 10 joints at one session. So this was both shoulders, both hips, knees, ankles, and patient had a hallux deformation. In one patient, 10 injections. Well, so at least the patient had enough fat to, yes, the patient survived. She was very happy, and especially because she lost so much weight. And but as you can see, there is a number of situations when I would use it. Why does it look like this? Because I was one of the first. So when Giorgio and Carlo and Arnold they asked me, I, like every orthopedic surgeon, I choose the worst possible cases. I said, I'm gonna use it on this. So you could see I was using this for osteotomies, for meniscus sutures, for ACL, PCL. Very large number of indications. So this is probably one of the patients that had 10 injections in one knee. So you can in one body. So you can see there's a lot of lipogems coming from this one. So other non-classic indications for orthopedic surgeon is, well, this patient had the one on this side. I was doing knee injections, but she has also some ischemic problem with the skin, and of course there was some adhesions. This is all our reality. This patient had surgery before done around around the distal part of the femur. So she had a terrible scar. She asked me to fill it with and improve it while I was doing the joint injections. Of course, I was doing this because I was trained by Carlo Tremolada, so he was standing at my back and he was telling me what to do. So I do not recommend for everyone to do this. But if you have a plastic surgeon in your setting, I think it's a very good combination. And recently, when Carlo visited me in Warsaw and we're doing some surgery together, Carlo injected my patient with the lipogems in her face. So. It is again not. I don't do it. It was only one case we tried, but that's the advantage of having a plastic surgeon or reconstructive surgeon as your friend. So, thank you, Carlo. The patient is very happy. So another indication, the spine. I'm not going to talk about it. I just wanted to mention one of my colleagues. He's an experienced neurologist who does a lot of injections around the spine. He mostly uses some magic things, including steroids mostly. So I told him, why don't you try this? So the response from both surgeon and the neurologist and the patient was very positive. But I don't want to talk about the indications and the results, of course. Other things like femoral head necrosis, again, I have very good results with the osteotomy healing, significantly faster and better healing. So this is why I was encouraged to try it also for femoral head necrosis. So if you look at the study of the osteoarthritic knees, this is only 36 patients, because I had to exclude all those strange indications or patients that had surgeries before. So we wanted to select the group of patients that didn't have any treatment before, for at least for a year. They had no joint modifying procedures before, and they had, as you can see, most of them were not very active patients. And if you look at the Kellgren, it was mostly grade 2 and 3 for the majority of the patients. And they were followed up by clinical examination, X-rays, MRIs for now 3 years, but I'm going to show you the 2 years results. And all of them received only one single injection of Lipogems. So there was no recurrent injection. So as you can see, first of all, I'd like to explain this. This is visual analog pain scale. Why is it? Well, it's not so. There's not that much difference, although we can see improvement and it's quite stable, because most of those patients were patients who had mild osteoarthritis. So if I had someone who would require either osteotomy or another kind of surgery, these patients could also receive Lipogems from at my hospital, but I excluded them from the study. So this is why you see patients with relatively mild pain. But what was the main reason for patients to come and see me were the symptoms. So as you can see, the symptoms, activities of daily living, quality of life. This is why the patients came to me, because they wanted to. They were not interested mainly in pain. They wanted to improve the quality of life. So as you can see, of course, there is some scales you can see that 1 year seems like the optimal and the best result, is slightly better than 2 years, but in some not. But generally, at least I could say that this is quite impressive to have such an improvement from one single injection, no other procedures, no other surgical procedures for those patients, and it works for at least 2 years. So I can confirm this. So this is the worst that can happen to you. So smile and be happy, because this is the worst that happened. I didn't have any serious complications in terms of coming from the injection into the knee. The bruises, which usually disappear within a couple of weeks, this is not painful for the patient. They were just concerned about it, but I told them it's nothing. It heals quite well. There is in some of the patients, they have some light pain within 2-3 days after injection, which probably represents the volume of the Lipogems that is injected into the knee, and that's why at least this was my hypothesis. So some of the X-rays from the patients, as you can see, this patient she couldn't have a surgery because of chronic lymphedema. So she didn't respond for hyaluronic treatment that was done before. She had this is her standing X-ray before injection at 6 months and at 12 months. So I don't know if I can say that I can see widening of the joint space, but at least it's not worse. But definitely there is a significant clinical improvement in these patients, and I think that this X-ray confirms the clinical findings. Another example, the patient with the cartilage defect, I treated him before he had a lateral meniscus sutured, so he came back after some time, and so this is after 5 months. You could see there's much less fluid in the knee, and of course also the meniscus looks better, and I think that this cartilage superficial defect looks also better. And this is another interesting case. This patient had a TrueFit implantation, not done by me, but by one of my colleagues. When he came to me, I had to clean, debride this large defect. I performed the high tibial osteotomy, and after some time he came back to me and he was still having some little problems with his knee. So we offered him the Lipogems injection, and this is something very, very interesting. First of all, look at the bone, how it healed within 3 months. There's significant difference in terms of the signal from the bone. Look at the defect. You see there's a little bit more tissue covering this, and that's very nice. You see he had a medial meniscectomy done 30 years before. And I probably I cannot call it a meniscus, but this is meniscoid kind of tissue, I think, that looks like it grew within the 3 months. I don't know, but at least there is an evidence in animal studies. There were some experiments done on the goats when they had a meniscectomy and they had stem cells injections, and the study was designed to see the osteoarthritic. The potential treatment for osteoarthritis, but those goats regrow the meniscus after cells injection. So this is similar. So to conclude, I think that this is an effective procedure. We can see there is significant improvement at 2 years follow-up, and there is also some evidence on X-rays and MRI of some structural regeneration of cartilage and the meniscus. And by the end, I'd like to invite you to my meeting that's going to be organized in Warsaw in September 14. As you can see, many of the faculty from today, Professor Kaplan, Professor Tremolada, Adrian, and many others, Lisa Kohn, they all going to be there, and I hope you visit Warsaw for September. Thank you.
Fantastic.